patients. There is another talk on conservative management, so I'll just go to the surgical aspects and particularly THR and main. So, treatment for AVN is stage-based. We all know that in the pre-collapse stage, we can try for head-preserving surgeries. Once collapse happens, then most of the operative or head-preserving surgeries do not work, and when symptoms warrant, they require a THR. So in a 37-year-old male like this, he had AVN on both sides. Again, lateral view is important to decide whether collapse has happened or not. Many of the times we might miss it on the AP view. A frog-like lateral view would help. So in these patients, we generally resort to a core decompression and BMAC injection. That's probably the simplest procedure without additional comorbids. So whether to add BMAC has been a debate. There is some advantage of adding a bone marrow or a processed bone marrow along with the core decompression procedure. And that is an effort to preserve the head. However, a lot of us, I'm sure, have faced patients like these where head looks good before, 42-year-old, no collapse of the head, core decompression had been done. But if you look at 1 year follow-up, there is subtle collapse in this region. And then at 3 years, he came with a picture like this and required a hip replacement. So the Ortho has come out with another set of classification for early femoral head osteonecrosis. They use two important landmarks. One is the femoral head apex and the lateral edge of the acetabulum. This is only for early necrosis without collapse. So type 1 is a small lesion that is medial to the femoral head apex. Type 2 is a lesion that goes lateral to the femoral head apex, but it is still medial to the lateral edge of the acetabulum. And type 3 is a large lesion that extends beyond the lateral edge of the acetabulum. So this is a new classification that came out in 2021, and they have shown it is a very valid prognostic marker. In type 1 and type 2, the progression of disease was 0 and 19% only, but in type 3, radiological incidence of progression was 87%. Only in type 1, 5% needed THR, type 2, 7%, in type 3, 31% needed THR. So even if there is no collapse and if it is a large lesion extended beyond the lateral edge of the acetabulum, probably we should not be recommending femoral head preserving procedures. So this was a 42-year-old male. You can see that the head contour looks pretty well preserved, but the lesion is extending lateral to the edge of the acetabulum. And in 1 year, his symptoms worsened, and we had to do a bilateral THR for him. So in THR, is there anything different that we do for AVN? Because it looks most of the time like a very simple primary hip. However, if you look at studies, the revision rate for AVN was historically higher as compared to THR for osteoarthritis, even when the age was adjusted. And they noted more acetabular site failures. However, with the newer generation, things seem to have cooled down. If you look at studies performed before 1990, the revision rate was 17% at 9 years for AVN compared to only about less than 10% for osteoarthritis. However, if you look at studies done after 1990, it has dropped down to 3% at 6 years. And with the current generation implants and techniques, the outcomes for AVN are almost equivalent to outcomes for osteoarthritis. So on the left, you have a 93-year-old male with pre-existing osteoarthritis and a femoral neck fracture, and he is certainly a different candidate from a 20-year-old male patient with AVN who is the breadwinner for his family. These patients are generally middle-aged people or young people who are in their working category, and they need longevity. Here it is at a premium. So we look at possible bearing surfaces and precise positioning of components. And we need to restore function for them with good biomechanics. And these are breadwinners, so I think early return to function and work is more important for them. So as far as longevity is concerned, bearing surfaces play an important role. This is data from the Australian registry. You can see that the bottom of the table with the lowest revision rates are oxinium on highly cross-linked poly and ceramic on highly cross-linked poly. Metal on XLPE comes a little bit higher and ceramic on ceramic even higher. Similar data in the UK registry. So I think ceramic or oxynium with XLPE probably is the best bearing choice, as it is more forgiving in today's world. Ceramic on ceramic is an unrealized promise. Wear rates is low, but on the whole, revision rates seem to be higher. So similarly, you can see the trend in the UK registry. Ceramic on polyethylene seems to be rising in popularity as compared to ceramic on ceramic. Secondly, accurate positioning of components. I think technology has a role. This is a study done with an experienced surgeon. In his last 100 manual hips, 45% of the cups were in the target zone as compared to 76% with the first 100 robotics. So I think technology plays a role in getting very reproducible X-rays. These are a set of 10 X-rays from my initial 10 hips with robotic DHR, and you can see that the component placement is fairly very reproducible with the robotic technique. And it also helps you restore biomechanics in terms of leg length and offset, as Rohit already showed. And for early return to work, we use the direct anterior approach in most of these patients who do not have most major deformities or difficulties with the primary. Rohit has already given a detailed talk on how it is an internervous and a truly intermuscular plane. This is the approach that we use for most simple AVNs. We also try to get a C-arm and see the leg length and offset intraoperatively. And you can get reliable function. Early, this was the patient working on day 5. Videos. So these are the patients on like 6 weeks walking, climbing stairs, and able to comfortably sit up and getting from a standing position. So in summary, non-orthoplasty options in the pre-collapse stage. Ortho 2021 helps to choose even in the non-collapse stages where to avoid an extensive lesion. Post-collapse THA is very helpful, and in current technology, it is as good as THR for osteoarthritis. Young patients are often breadwinners. Longevity, functional outcome, and early return to work are at a premium for them. Thanks for the opportunity.